Good morning, good evening, and good night from everyone across the globe that's joining us for this edition of the EIOC Journal Club. We are going to be talking today about redefining progression in ER-positive, HER2-negative advanced breast cancer, really looking at the newer modalities of therapy and insights from emerging clinical evidence. My name is Shaheenah Dawoud, and I'm a consultant medical oncologist coming to you all the way from the very sunny, very warm, and very safe United Arab Emirates. And I'm joined today by some spectacular faculty, both regionally as well as internationally. And I'm going to allow them to introduce themselves. So, Erica, first of all, thank you for joining us on this edition of the EIOC. I know you've got a very busy schedule, but please introduce yourself.
Thank you so much, Shaheenah. Thanks, everybody. I'm so happy to be here with you. I'm Erica Mayer. I'm a breast cancer medical oncologist at Dana-Farber Cancer Institute in Boston in the United States. So thanks so much for having me.
Aref.
Yeah, hi everybody. Aref Chahal, medical oncologist, Sheikh Shakhbut Medical City, Abu Dhabi.
Dalia El Shorbagy, medical oncologist, Sheikh Shakhbut Medical City, Abu Dhabi.
And Emad.
Hello everyone, I'm Emad Dawoud, medical oncology consultant, Dawam Hospital Ain.
And Husam.
I'm Husam Marashi. I'm a consultant medical oncologist based also at Dawam Hospital, Al Ain, east of the United Arab Emirates.
And Maroun.
I'm a consultant oncologist at American Hospital in Dubai.
So without further ado, I am going to share my slides, if I can find my slides. And this is the agenda, but we're going to try and make it as interactive as possible. And I promise not to bore you with a very, very long discussion. Okay, how do I do this? Replace current share. Can you all see my slides?
Not yet.
Yes.
Yes. All right, so these are my disclosures, and if anyone would like to get in touch with me offline, I'd highly recommend that you scan the QR code. Now, a lot of you have seen this slide that I created a couple of years ago, really looking at these patients with hormone receptor positive, HER2 negative metastatic breast cancer. We know that we start off with an endocrine sensitive tumor going all the way to endocrine resistant and then endocrine refractory tumors. And at each point of progression of disease, we can in fact identify different biomarkers, because we know that biology changes over time and new targets tend to emerge. Now, Dr. Aref, do you determine biomarkers for all your patients at diagnosis of metastatic breast cancer?
Yeah, I mean, for hormone positive, HER2 negative disease, we have the essential one, the estrogen receptor, progesterone receptors, HER2 status, Ki67. If you are talking about the PIK3 and DSR mutations, usually currently, we don't do it from the first time of diagnosis. Currently, we do it, upon first relapse or progression.
Erica, what happens at your end? Does everyone with metastatic hormone receptor positive breast cancer, do they all get comprehensive genomic profiling done at diagnosis? And if so, why?
Yeah, so we do try to obtain NGS testing for all of our patients newly diagnosed with metastatic hormone receptor positive HER2 negative breast cancer. There are two ways we can accomplish this. One would be tissue based and one would be ctDNA based. Ideally, we have a tissue biopsy for all of our patients to confirm that they do indeed have metastatic disease, and as was just said, to confirm ER+, HER2. And so we will send that sample, but we also like to send ctDNA at the same time. And the reason for this is that different mutations can be detected slightly preferentially based on tissue versus blood. For example, PIK3CA mutations are preferentially detected out of tissue. These are truncal mutations, so they will be present in the biopsy sample. They might have been present in the primary disease, versus ctDNA, which is perhaps better at assessing for ESR1 mutation, something infrequently found at time of initial diagnosis, but can be found later. And we do know that ctDNA also gives you a little bit more of a kind of 360 view of the body, since you're really assessing everything as opposed to an isolated liver lesion or a lung lesion. So ideally, I try to do both at the time of diagnosis. We don't do it 100% of the time, but that's our goal.
I agree, but the problem that we face here is that insurance doesn't always allow us to do both, but I completely agree with you. I think ideally we should be doing both. Dalia, how often do you repeat biomarker testing? And if you're going to repeat it, what methodology are you using?
I repeat it honestly if I'm gonna change the treatment of the patient, but I think with the emerging data now, I think we need to follow at least the SAR if there are any emerging, especially if the patient on say first line CDK4/6 inhibitor. How I prefer to do it by liquid because it will give us information about most of the biomarker available if it is there, especially these are children.
Okay. And so we've had a lot of real world data that's actually told us what happens to these patients in the first year, the second year, and then so on and so forth. And this comes from the German research network that looked at patients from 2014 to 2022. And what they essentially showed that with patients who experience disease progression, there's a 52% probability of progressing to second line therapy within 2 years of actually commencing therapy. So Maroun, how do you anticipate second line attrition and how do you manage this?
I mean, reaching second line is very common in these patients. I think most of them would have received CDK4/6 and AI, for example. And when you reach the second line, as my colleague mentioned, we usually typically do another liquid NGS to see if we can catch another mutation. But to answer your first question, we usually do also a comprehensive NGS on the tissue up front. And then once they reach the second line, then we have to decide about the second line treatment depending on the results of the liquid NGS.
So Erica, let me give you a different scenario. So we all have these patients who are on first line CDK4/6 inhibitors plus endocrine therapy, and they're doing very well, even if they had come in with horrible visceral mets. We've seen them do very well with that first line CDK4/6 plus AI or fulvestrant, whatever it is that we give them in that first line setting. And some of these patients actually do stay on it long term. But we do see that sometimes when they progress, even after 2 to 3 years of CDK4/6, they can sometimes progress very rapidly and you lose control over that disease. So in your experience, how often does that happen? And how do you anticipate that happening? Because there's this inherent thing in the community that if your patient's been on a CDK4/6 inhibitor for 4 or 5 years, they're going to do very well even upon progression, which is not always true.
Yeah, I think all of this really demonstrates to us how incredibly heterogeneous hormone receptor positive HER2 negative disease can be. And we have patients who have endocrine resistant disease at time of initial diagnosis who progress fairly quickly into their second line treatment, if that is even endocrine based, versus these, we might call them exceptional responders, who were able to stay on their first line therapy for many years. And it's actually interesting in that German database figure that you showed us that at year 10, there's still 20% of patients who have not progressed. We're looking at the 80% who have, but remember, there's 20% who have not. So we do have a population of people who, with first-line therapy, whether it's endocrine alone or endocrine with CDK4/6 inhibitor, do have these exceptional responses. But I think you're absolutely right that even when these long-term responders progress, it's difficult to know what's driving that and what the behavior will be. And as much as we hope that we will continue to see this very nice endocrine sensitivity, the mechanism that's driving progression may not allow that. That supports the need to recheck the NGS. And I would say also in these long-term responders who progress, often we might want to rebiopsy them to make sure they still retain estrogen receptor and they have not evolved into more of a triple negative phenotype. So I think it's, for all of us, we probably have, collective decades of treating cancer patients, but it's still humbling when we have these cases where you think you know what's going to happen, but it turns out to be a different way.
Absolutely. I currently have a lady that's been on a CDK4/6 plus endocrine therapy it was an aromatase inhibitor for literally 8 years. She has now started to progress, and nothing I'm throwing at her is still ER+, positive, HER2 negative. Nothing I'm giving her seems to be working in terms of endocrine therapy. And I'm very quickly going to now start systemic chemotherapy for her. And even though she was on it for 8 years, this patient no longer has endocrine sensitive disease at the time of progression. Like you said, not everyone is going to do the same. Husam, this question is for you. What percentage of your patients actually make it to third line therapy and still are on endocrine therapy?
I don't have the exact figures, but I guess will be something like between 20 to 30%. And I'm saying that because, as you said, once you move into the second line, it's quite difficult to predict what's going to happen. You start to get these clinical reviews more often and try to make sure they are under close monitoring. You insist on repeating imaging and try to monitor, how they're doing. But there are some proportion. I guess that just a quarter of the patient then go, and you try to go and target whatever you haven't targeted at the start. So those, for example, who you have ESR1 just emerged, or you have like PIK3 wasn't tested in the first line. Again, you expect from moving one line to another that the response may not be as good as the line before that. So that's how we deal with it.
Okay. So now let's go into a deep dive into the phase 3 INAVO 120 trial. As you all remember, these were patients who had either recurred while on adjuvant endocrine therapy or very quickly post-completion of their adjuvant endocrine therapy. These patients had a PIK3CA mutation that was detected either by tissue or ctDNA. And these patients were randomized to get either triplet therapy with inavolisib plus palbo plus fulvestrant versus just palbociclib plus fulvestrant. Primary endpoint was progression-free survival that was investigator assessed. And we know that 34% of these patients had primary endocrine resistance. The rest had secondary endocrine resistance, with very few patients, only 1.9% of patients having received adjuvant CDK4/6. Now, when the data was first presented by Como at San Antonio in 2023, at a median follow-up of 21.3 months, we saw a very nice separation of the Kaplan-Meier curves in terms of the progression-free survival, with an improvement in PFS from 7.3 months to 15 months. This was statistically significant, 57% reduction in the risk of progression of disease. And then last year at ASCO, we saw a significant improvement in overall survival, where the median OS improved from 27 months to 34 months. Erica, were you surprised with the overall survival results that we saw in the INAVO study?
Yeah, I think this is a really important study and has really changed our paradigm of how we address patients in the first line setting. Exactly as you point out, these are high-risk patients recurring on or soon after their aromatase inhibitor. These are not patients who recurred years after completing. These are not de novo patients, but these are already high risk, and they're patients with PIK3CA mutation. And I think we see this in the control arm of the study. Having a median PFS of only 7 months is really pretty dismal compared to what we see from the first-line CDK4/6 inhibitor trials. And so, in a population with very aggressive tumor biology, it is unlikely they will go on to receive multiple subsequent lines of therapy. And so in that setting, it is possible to see overall survival benefits. I do think it's important when we assess the trial, though, to consider what did they go on to receive next, because we don't have a lot of crossover to get subsequent PI3 kinase inhibitor. It was really, first time or almost never. And also the population of patients may be a little different than who we normally are taking care of. I think like half the patients recurred on or soon after adjuvant tamoxifen, not aromatase inhibitor. And so perhaps they were, So they were maybe a little less treated than the typical population for us, where we are giving aromatase inhibitor to many patients.
If I may interrupt you, Erica, this is a very important point that you're bringing up, that almost half these patients had received tamoxifen and not an aromatase inhibitor in that early stage setting. If they had all gone on to receive an aromatase inhibitor, would we have seen a different result versus half not having received an aromatase inhibitor in that early stage setting? Because a lot of we don't give fulvestrant to patients who have relapsed on tamoxifen. The standard of care would be to give an aromatase inhibitor. So what are your thoughts here regarding that?
Yeah, I think that makes it a little difficult to interpret the data in many of our contemporary populations where, exactly as you say, if you recur on tamoxifen, which, we're only giving tamoxifen to the very low risk premenopausal patients. If you're recurring on that, then we would be giving aromatase inhibitor next. So the treatment pathway is a little different than what we normally do. And the mechanisms of endocrine resistance after recurrence on tamoxifen may be different than that on aromatase inhibitor. So it's possible if the population had less tamoxifen and more aromatase inhibitor prior treatment, we might have seen a different response. But, of course, that's all, guessing. We don't know that for sure.
So one of the questions I really wanted to ask you, Erica, and it's every time I see this study, I go back to the inclusion criteria. They looked at patients who had recurred on endocrine therapy in the adjuvant setting or within 12 months of completion. Now, two scenarios here. You have a patient that's recurred within 6 months of starting adjuvant endocrine therapy. Actually, three scenarios. You have a patient that has received 10 years of endocrine therapy and then recurred at the 10th year. And then you have that patient who's recurred 12 months or literally at that edge, 12 months post completion of adjuvant endocrine therapy. Do they all do the same? Are they all the same? Do they all need triplet therapy? Is my question. Because they've all got PIK3CA mutations. Do they all need the same? Because nowadays we give adjuvant endocrine therapy beyond 5 years.
Yeah, I think that's a terrific point, and again speaks to the heterogeneity of the population. I would say though that they all did have PI3 kinase mutations, which
Yes.
we see in about 40% of hormone receptor positive breast cancer and is associated with endocrine resistance and inferior outcomes. So even if my patient did have a long disease-free interval, if they have the PIK3CA mutation, of course I want to give them a PI3 kinase inhibitor. But it is a very good question. Does it matter if we give it first or if we give it later? And for example, the Capitello 292 study is looking at this question of giving capivasertib first line or delaying it for later. And I think that those are important questions, as we may not necessarily want to be giving this Inavo triplet to every single one of our first line patients, especially given that it's a fairly rigorous regimen and has a fair amount of associated side effects.
So, Imad, do you think palbociclib was the best partner for this particular trial?
Thank you, Shaheenah. I believe it's the best partner because of the safety profile. So we're looking for the most of the combination they choose palbociclib probably because of the safety profile of the palbociclib. And I believe the CDK4/6 inhibitor in this setting, they all give the same efficacy, at least for the progression-free survival.
Okay. So now let's go to some of the data that was presented at San Antonio, looking at the subgroup analysis based on the PIK3CA type of mutation, whether there was ESR1 mutation detected versus not, and then of course looking at that ctDNA tumor fraction. And again, they seem to have the same efficacy. So Erica, if I can go back to you, if your patient who has a PIK3CA mutation. Now, this is probably totally hypothetical, but your patient has the same criteria of Inavo, has recurred, has a co-mutation of an ESR1 mutation and a PIK3CA mutation, but the tumor burden is really low, and you're allowed to use combos. What would you target in such a patient? Because according to this, it didn't really matter if the patient had an ESR1 mutation or not, or even looking at the ctDNA tumor fraction, everyone seemed to do good by adding inavolisib.
Yeah, the topic of co-mutations is something that we speak about quite frequently, although it, as you point out in that figure, is only about 15% of our patient population. We now have data both from this study as well as the major oral SERD studies, as well as other PI3 kinase experiences demonstrating that in the setting of co-mutations, the targeted agents all appear to have activity. And so it brings up the question, is it best to target ESR1 or target PI3 kinase? And I think, as you point out, there's a lot of hypotheticals here as to what would be the ways in which we would target each of those mutations. Currently, if we are using in my country, FDA-approved oral SERD strategies, these are exclusively monotherapy strategies which have a role for specific patients, but generally are not necessarily what we would reach for when we are looking for our greatest activity and efficacy, particularly in a setting where it doesn't totally match the approved indication. I have to say that I am a little humbled. I feel humbled by PI3 kinase mutations in terms of their consistently demonstrating inferior outcomes compared to PIK3CA wild type situations. And so I have a tendency to lean into wanting to target the ESR1 mutation first as a way to provide the greatest efficacy to a likely resistant cancer. But I think in our hypothetical future, what we would really like to have is a combination of both, something targeting ESR1 and something targeting the PAM pathway. And those regimens are in development right now, but that would be our best way to target a dual mutated patient.
Dalia, you had a question?
Yeah, actually, I have a question because nowadays we are trying to find the ASR mutation. We are doing the ASR by liquid for patient on first line CDK4/6 inhibitor. But honestly speaking, I'm discovering many patients with PIK3 or AKT pathway alteration. So what do you do, Erica, for this group of patients? Do you
I'm going to
maintain?
come to that. I'm going to come to that, Dalia. Please don't jump the thing. I'm going to come to that, and I'm going to question Erica left, right, and center when it
Okay.
Capitello 291. Capitello 291 is a phase 3 randomized double-blind placebo-controlled trial that took patients who were endocrine-resistant patients who had progressed on prior endocrine therapy. Up to 2 lines were allowed of prior endocrine therapy, and at least 1 line of chemotherapy was allowed. And at least 50% of patients could have had prior CDK4/6 inhibitor. Actually, in the trial, 70% had received prior CDK4/6 inhibitor. They were randomized, irrespective of the biomarker, to either capi plus fulvestrant versus placebo plus fulvestrant. There were dual primary endpoints of PFS in the overall cohort as well as in the AKT altered pathway cohort. And you can see in that dual primary endpoint in the PFS overall population, PFS improved from 3.6 months to 7.2 months with a 40% reduction in the risk of progression of disease. And in the AKT altered pathway, you can see it improved from 3.1 months to 7.3 months with a 50% reduction in the risk of progression of disease. Now, Erica, I have to ask you this question because, the FDA is in your country after all. Why did the FDA only approve Capitello for the AKT altered pathway cohort of patients when it seemed to be working for everyone?
Yeah, so that's a great question, and I will just say I can't try to channel the FDA necessarily because we never know exactly what they're thinking. But the population, as you point out, was not biomarker selected, although it was in some ways enriched for patients with AKT pathway alterations, and we definitely see our strongest signal here with the hazard ratio 0.5. The hazard ratio in the ITT population is 0.6. Well, what about the people who did not have a pathway alteration? Exploratory analyses looking at those without the pathway alteration and including the unknowns showed a hazard ratio of 0.7. And if the unknowns were removed and it was strictly the patients who had no PI3 kinase pathway mutation, the hazard ratio was 0.8. It just sort of keeps climbing up. And I think that data, which exists in sort of supplemental figures in New England Journal papers, begins to unravel this story a little bit and suggesting that the greatest benefits of capivasertib are really in patients who have these PAM pathway, PI3 kinase, AKT, PTEN, or mTOR alterations.
So now when you look at patients who had prior CDK4 exposure versus without, you can see there was a benefit irrespective of the prior CDK4/6 exposure. And then when you look at the ESMO update of a subgroup analysis, again, it was post-hoc analysis, and I really like this part where you see those patients chemo-naive, first-line therapy with capi plus fulvestrant. That PFS is actually quite interesting. It improves from 3.7 months to 14.3 months. Maroun, what are your thoughts about this? Would it be a situation where you can see yourself where you don't have inavolisib or it's just really, really expensive and someone has relapsed rather quickly on adjuvant endocrine therapy? Would you consider a Capitello 291 protocol in that patient looking at this data?
As first line? As first line, I think I would go with first line. They relapsed on AI, And so my first line would be CDK4/6 inhibitor, or Inavo if they have the PIK3. If they have, so your question, if they have the AKT pathway, do I use first line Capitello?
Capitello. Let me come back to you. Let me come back to you, Maroun. Erica, if a patient is unable to get triplet therapy for whatever reason, would you give Capitello 291 first line in a patient with a PIK3CA mutation or an alteration in that AKT pathway?
Yeah, I
Looking
mean, I think it's very tempting, but look how small those numbers are. It's a very
Yes.
small fraction of the entire population, and it wasn't really who this study was designed to evaluate. It's not part of our drug approval. So we generally are not giving Capitello 291 to our first line patients. As I mentioned, there's Capitello 292 trial that's going on that's looking at this question in the first line setting. And that's a great trial to study it. But for us, we would not be doing it despite this really interesting and provocative data.
All right, now let's move over to what's the new kid on the block, which are the oral SERDs. Now we have a number of clinical trials, but the three most important ones that looks at SERD monotherapy includes the Emerald trial, Serena-2, and the AMBER-3 trial that randomized patients to get either single-agent oral SERD or standard of care endocrine therapy. And you can see right off the bat in those patients who've got an ESR1 mutation, using an oral SERD trumped using standard of care endocrine therapy. However, you do see at the top of the Kaplan-Meier curves at least a 60% drop-off where whatever you're giving to the patient is actually not working over here, telling us that single-agent endocrine therapy is probably not the best strategy, at least in those 60% of the patients. Now, AMBER-3 also looked at the combination of imlunestrant plus abemaciclib, comparing it to imlunestrant, and we know that this was an add-on arm of the study. And what you essentially see right off the bat is that, yes, you're still seeing a drop-off. The combo is better than single-agent imlunestrant, but that drop-off is a lot less. It's now about 15 to 30%, telling us combination is better than using single-agent oral SERDs. Last year at San Antonio, we saw the translational component of the AMBER-3 actually being presented, and you can see that when you're looking at that ESR1 mutation VAF, with standard of care endocrine therapy is the black bell-shaped diagram, and then you got imlunestrant where it has reduced the VAF of ESR1 mutations, but it's really the combo that's further reducing and recognizing that all these patients had received CDK4/6 inhibitor in that first line setting. Now, when you're looking at the molecular response, again, the molecular response was associated with a more prolonged progression-free survival. You can see standard of care endocrine therapy, it's 7.4 months, imlunestrant alone, 9.2 months, but it's that combo where you're getting the best molecular response of a PFS of almost 11 months. So, Husam, how often do you test for ESR1 mutation? I haven't come to Serena-6 yet, so please don't jump. So how often do you test right now in your clinic? How often do you test for ESR1 mutation? What
We are quite
drives your
comfortable.
mutation?
Yeah, I think important question now in the clinic nowadays, because now we are tempted to check after each progression. You just go and you will look for that mutation. I'm not talking about emerging yet. I'm not talking about molecular progression. I'm just talking about someone have radiological or clinical progression. I'm tempted to repeat the liquid DNA, circulating DNA, and just look for that fraction of ESR1 in case it's emerged, because I know the medication now, we're quite familiar now with it after the Emerald study. And I know the side effects is very, very reasonable, very tolerable drug. So I'm very comfortable to look for it at each level. Now, once I reach chemotherapy, possibly I wouldn't check that's often for the ESR emergence, but for endocrine, 100%.
All right. Now, Erica, we have seen data from Serena-2 that tells us if you use an oral SERD in those patients with multiple ESR1 mutations, PFS is abysmal. But if it's one ESR1 mutation, it's actually much better. Does this drive your decision making in the clinic when you're trying to target the ESR1 pathway?
Well, it's actually quite a minority of patients who will have multiple ESR1 mutations. So that's not the most common patient to see. But I think actually like my main feeling about the oral SERDs right now, and it's actually getting to question 3 on here, is how should we be using them? And using them as monotherapy while in a select group of patients, who we can identify based on markers of endocrine sensitivity and perhaps disease burden, single agent oral SERD can be a very reasonable choice. For many other patients, there are too many mechanisms of resistance, and the oral SERD monotherapy is not adequate to overcome that. And I think the idea of having multiple mutations is really reflecting that the patient's disease is too resistant for monotherapy. And this is what we see in those figures that you showed. That very steep drop off is showing us that a large percentage of patients enrolled onto those studies had primary or had endocrine resistance such that oral SERD is not enough. And what we need are the combinations like you showed in EMBER-3 or perhaps in the AVERA study of giredestrant and everolimus, where you're targeting 2 different resistance pathways, and that provides greater ability to overcome the resistance. So although for me, I occasionally use oral SERD monotherapy in a select patient population, my interest for my patients is much more in using combinations that have that dual targeting capacity.
So, Erica, let me give you a clinical scenario that Husam was actually mentioning. You have a patient in the clinic who has received all the lines of endocrine therapy, has now received all the ADCs, and is still in good performance status. And you see that this patient has an ESR1 mutation, but a heavy burden of disease. And you decide to use combo endocrine therapy with an oral SERD and maybe a CDK4/6 or everolimus, as per the AVERA study. What is your predicted probability of that patient actually responding to the combo at that time point?
Well, that's a great question because I'm doing that right now in clinic with a patient who's in that situation. So, on the one hand, I think that if I had to pick my best option for that patient out of the endocrine category, it would be a combination of SERD with targeted agent. For example, as you put here, abemaciclib and imlunestrant, which is the one that I might be able to access in my country. In all honesty, though, a patient who has demonstrated resistance to multiple lines of endocrine therapy and multiple ADCs, they are perhaps less likely or unlikely to achieve a sustained response from that type of regimen. So my expectations are fairly low, shall we say? But if I want to do that, then this would be my best choice in that setting.
But
Emad,
can I
yes,
say
go ahead.
something, Shaheenah?
Yes,
I
yes.
think it's really unfair. The problem with Emerald is that quarter of the patient have Faslodex and quarter of them have chemotherapy. So I don't think that was the best use for ESR1 to leave it that late for monotherapy.
But I'm sorry, Sam, I tend to disagree with you. I think that yes,
Well,
Emerald was a very heterogeneous population where they did have patients who'd received chemo and it was more heavily pretreated. But when you go on to AMBER, that single monotherapy arm of immunolestrant again didn't exhibit what we thought they would exhibit, because these were not patients who received chemotherapy in the metastatic setting. So for me, single agent oral SERD is not as good as combo. Erica, would you agree?
absolutely agree with you. No, I agree with you. But just the idea of targeting ESR1 really late is not going to be fruitful, even with the combination, as Dr. Erica said. And I don't know, I'm going to ask her another question. Did she have any concern about the hazard ratio for overall survival was 1.22 in the combination ESR1, or are you still happy to apply it in your clinic?
I think that survival is well, that was an immature rate, immature value. This was, I think, the most recent data that Dr.
Yes.
Javeri presented at San Antonio, which again, this remains immature. It has not crossed this threshold for significance, but it's an interesting separation of the curves. It is a little hard for me to believe that imlunestrant monotherapy is going to have an overall survival advantage, given that we just don't tend to see a lot of activity of this agent in this endocrine resistant population. So of course, we'll continue to monitor this, but it's an interesting signal.
Absolutely. And then when you look at the interim overall survival analysis of imlunestrant plus abema versus imlunestrant, again, I don't think the comparison was correct. in terms of you comparing the combo with the single agent. But again, you can see the Kaplan-Meier curves are practically overlapping each other. I think you need more follow-up and you need more events before we can make any sort of tentative conclusions. So let's now jump on to Evera, which is again something that everyone's talking about, not because of the oral SERD, but because of the combo that's being used with the oral SERD. Again, these were 100% of patients received prior CDK4/6 inhibitor, 70% received one line of therapy. These patients were randomized to get giredestrant plus everolimus versus standard of care endocrine therapy plus everolimus. I love the design of this trial because here at least the comparator arm, you have a combo going on so that it's a good comparison. And as you can see in your ESR1 mutation cohort, PFS improves from 5.4 months to 9.9 months in the intent to treat population. Again, there is an improvement in the PFS with the combo of oral SERD plus everolimus. Again, I'm seeing that drop off, but Erica, am I just being, naive here? When I see the ESR1 mutation cohort, that drop off is there, but not as significant as what we saw just visually from AMBER-3. What are your thoughts here? I feel like there's more of a separation, there's less of a drop off in that ESR1 mutation cohort for some simple combo of an oral SERD with everolimus.
Yeah, I agree with you. I mean, from my perspective, I think those curves begin to separate very early. And this is a very different shape of the Kaplan-Meier curve compared to the oral SERD monotherapy, where we see that like steep, waterfall that happens at time of first restaging. Here, even before the first scan has happened, it appears that the curves are beginning to separate. So I definitely think that there's something here. And again, it supports this idea of oral SERD combination treatments.
And what are your thoughts about the fact that everolimus was practically a dead drug and is now re-emerged into oncology practice? Are you going to start using more everolimus? It's cheaper, and for me, it's something different from a CDK4/6 inhibitor because there's still this hesitancy in the community, despite post-Monarch, despite AMBER-3, despite even SERENA-6. You now have Evera that's telling you, perhaps we can use everolimus instead of a CDK4/6 inhibitor. What are your thoughts there?
Yeah, so everolimus was never a dead drug for me. I've always been using it. I think that the challenge has been the toxicity thresholds, and I find the data from the SWISH study, which is looking at prophylactic steroid mouthwash, was very helpful in allowing me to more comfortably give this agent to patients. As before we had that data, the rates of stomatitis really made it very challenging for patients. I also think that sometimes early dose reduction is helpful to get to the right dose for a patient. But I think you're absolutely right. Everolimus, it's a classic drug. We understand it well. It's easy to take. It's cheap. And I think in this design, having that as a comparison, well, perhaps not our most commonly used regimen, but it's a combination regimen. So it really makes sense, and I think helps to support the giredestrant everolimus arm of this trial.
Aref, what is your experience using everolimus, and do you think Evera, if it's approved, is going to change clinical practice?
Thank you. I think the use of SERD with everolimus is not something new. Probably from the time of Bolero, we have using tamoxifen plus everolimus, aromatase inhibitor, fulvestrant plus everolimus. But at that time, there was no CDK4/6 inhibitor. But I mean, even, at that time, the Bolero study showed significant benefit, even irrespective of PIK3 in intent to treat population, as I remember. And we were using everolimus with exemestane also a lot previously. So I still using, as Professor said, everolimus, but I think now with the oral SERD, it will be more convenient than the injections, and I think this combination is really promising.
So now let's switch over to SERENA-6, which is, I think, the most innovative clinical trial design that we've seen in a long time. Although, yes, it's also sparked a lot of controversy in the oncology community. And I know that Erica and gang have been trying to fight off fires for quite some time with the trial design. So here, this is a phase 3 randomized double-blind placebo-controlled study taking patients who'd received first-line AI plus CDK4/6 inhibitor in that metastatic setting. They had to be on therapy for at least 6 months, no radiological progression of disease at the time of detection of ESR1 mutation by ctDNA. These patients were randomized to receive either camizestrant and the same CDK4/6 inhibitor versus continuing the AI plus the same CDK4/6 inhibitor. The primary endpoint was progression-free survival. When you look to see which CDK4/6 inhibitors patients were on, more than 76% of patients were actually on palbociclib, with the rest receiving ribociclib and abemaciclib. In that primary endpoint of PFS, you can see a very early separation in the Kaplan-Meier curves, practically no drop-off. You can see the PFS actually improved from 9.2 months to 16.6 months. Hazard ratio 0.46. When you look at the PFS2, you can see again a separation in the Kaplan-Meier curves. It improves from 19.4 months to 25.7 months, but at radiological progression, crossover was not allowed, and I know there was a lot of controversy regarding this point. Although whenever I think about the controversy, I think to myself, but oral SERDs were not even approved at that time to use in the second-line setting. So how would you do that type of crossover was something I'd never understood with that particular argument. So, Emad, which part of SERENA-6 data do you find most compelling?
Progression-free survival. I think delaying the PFS by almost 7 months for this group of patients, this is quite interesting. And I'm from those who believe that the ESR inhibitor should be used in combination. I don't use it in monotherapy unless the very, very few cases. Use it in early when just biochemical progression in the form of the worm ESR1 mutation. It's quite effective and delayed the radiological progression. And even I was wondering why not they used it from the initiation of the CDK4/6 inhibitor, just to prevent the development of ESR mutation, we might have even better outcome.
I will come to that. Hold your horses, Emad. Dalia, in your practice, what percentage of your first-line cohort do you think will qualify for SERENA-6? Dalia?
Actually, I'm testing. We are testing most of the patient now after at least 6 months from the first line. But how much will be qualified for the first line or for SERENA-6? I guess will be 30-40%. So this is the ESR mutation that we are expecting to happen during the CDK4 treatment.
So, Erica, one of the questions that Dalia wants to bring up, that I think now we can bring up, is we're all going, because in Dubai it's camizestrant has arrived, just to let you know, it's arrived in our clinics. We have a DDC code for it, so if anybody would like to actually prescribe it, it's there, it's available. I'm sure Erica is completely jealous of the fact that we have SERENA-6 now approved over here. But Erica, as we start to test, we're going to start to pick up not only ESR1 mutations, we're going to start to pick up PIK3CA mutations and other types of other mutations. And I can envision a clinical scenario where I'm testing for ESR1, but I'm seeing there's a PIK3CA mutation and the VAF is going up, and it's just a matter of time before I pick up something on a CT scan. How do I ethically not target it, now that we have the data for SERENA-6?
Yeah, it's a whole new world for us to think about not only looking at genomic profiling, but doing this in real time as patients are being treated. And I'm definitely jealous of you to now have access to SERENA-6 as a regimen. So, just thinking about those two very special actionable mutations, PI3 kinase and ESR1. Ideally, the PI3 kinase would have been detected at time of initial metastatic presentation, and perhaps that patient would have been shifted into the INAVO120 pathway or capivasertib, as we discussed before. And so, I'd see this as being perhaps a strategy more for patients who are PIK3CA negative or patients for whom you really don't feel like that's the right regimen for them. And thus you will have started them on first-line aromatase inhibitor and CDK4/6 inhibitor. I think it will be interesting to watch not only for emergence of ESR1, but also the fluctuations that may occur in both actionable and non-actionable mutations. It is also possible in the future that the testing that is needed for Serena-6 will not be a comprehensive NGS, but might be more of a mutation specific. So just looking for ESR1 instead of the whole panel. That might be a little bit of a faster and more cost-effective way to operationalize this. But it's a very good question, and I think as we begin doing this much more in practice, we're going to find ourselves facing these situations where it may not fit exactly the way it did in the trial, but we find ourselves with data that may encourage us to go in a different direction.
Dalia, you have a question?
Yeah, the same point actually. We know very well that the AKT pathway, they are the reason behind the resistant mechanism in patients with hormone receptor positive. So if the patient carry this mutation, whether we detect it through the testing with the ESR or we just test for ESR1, I think the patient is going to relapse eventually very quickly if the patient have this mutation in the tumor. So honestly, I don't know if the patient is with me in the clinic now and I detected during the ESR survey or testing, what I have to do, I just keep the patient and observe him for radiological progression to start on AKT pathway.
For now, Dalia, I completely agree with you. We're going to all come into that problem similarly, all of us. However, we have absolutely no data to switch therapy based on a rising VAF for PIK3CA mutation. And as such, we will have to wait for that emergence of an ESR1 mutation, or we would have to wait for radiological disease progression before we target the PIK3CA mutation pathway. Having said that, last year at
Can I say
San
something? Can I say something?
Yes,
I
yes,
think we
Maroun.
should limit the testing to the ESR1 because it will be very confusing if you do more than, if you're planning to follow the Serena, I think, which we started implementing in our practice. I think the challenge is just to limit the testing to ESR1. Otherwise, it will be.
Absolutely, but Maroun, a lot of us are also using Guardant or other types of kits that will give you comprehensive information irrespective. So we're all going to run into these problems. Last year at San Antonio, we saw
Can I just make one more point?
Yeah.
I think as we talk about these mutations and talk about the Serena-6 structure, what it's really built around is this idea of emergence of a mutation, that it didn't exist before, and then it exists and it increases because the cancer is in real time becoming resistant, but that hasn't actually led to cancer progression that we see on a scan that would trigger us to make a change in treatment. PIK3CA doesn't behave like this. It's the truncal mutation, so it's just there, but we wouldn't expect it necessarily to be evolving and have this kinetic process the way we do for ESR1. So I'm not sure that we could apply the Serena-6 approach to a truncal mutation instead of a clonal mutation, because it's really more about this idea of it being dynamic and changing as opposed to just detection.
So, Erica, I have a patient that I treated for stage 3 breast cancer about 10 years ago. And I'm one of those people that actually checks tumor markers every now and then. And I found 7 or 8 years later that her CA15-3 had started to increase. I did a scan, couldn't find anything, and I did a liquid biopsy. It was actually a Guardant liquid biopsy. And I found a very low VAF of a PIK3CA mutation. And again, CA15-3 continued to rise, multiple scans, nothing. And every time I did a liquid biopsy, I could see that VAF actually increasing. And eventually, 6 months later, she developed bone metastases when the VAF had reached, I think it was like 3 or 4%. So I do think, yes, I agree that the PIK3CA mutation is there from the very beginning. It's there on the tumor, but when the cancer begins to come back, it can also be a marker that the cancer is re-emerging prior to radiological, emergence of disease. So I think we probably have both scenarios that we're looking at, and I just wanted to tell you about my case where I actually did this a couple of years ago. All right, so this was the San
Next
Antonio.
generation medical oncology.
Yes.
There's
So
more work
this-
done. There's more work done on this. If you remember the French group, the PADA one, they published far more than Serena-6 so far. And
Yes,
they told
100%. And we're
some,
coming to that. We're coming to that, Husam.
we're coming to it.
Yes,
Okay.
yes.
There's
So
so many speakers
camizestrant
there.
in this translational component of Serena-6 tells us that when you give camizestrant, you're actually reducing the VAF of ESR1 mutation a lot more than if you just continue the AI plus CDK4/6, where you see the ESR1 mutation continuing to increase. So I did a thought experiment And I looked to see what if we changed and did an aBC type protocol in the second line setting versus Serena-6. So if you take the control arm of CAMI plus CDK4/6, in Serena-6, the PFS is 16 months from molecular progression to radiological progression. If you took the control arm of Serena-6 AI plus CDK4/6, it's 9.2 months from molecular progression to radiological progression. If you then switched to aBC, aBC tells you imlunestrant abema is 11.1 months from radiological progression to radiological progression. So your PFS is actually a lot longer when you add the two, 20.3 months, asking the question, why the hell would we do Serena-6 in the clinic if you did an aBC type protocol? And I think the simple answer for me is that you're avoiding that drop off, because not everyone is going to be able to get onto an aBC type protocol, because some of them are going to not be able, they're going to be endocrine refractory, they will need chemotherapy. What are your thoughts here, Erica?
Yeah, I think it's an interesting thought experiment, although, it falls a little bit into the danger of doing cross-trial comparisons because there's differences in patient populations. I do think, though, as you point out, there is this benefit to the earlier introduction of this combination regimen, not only to provide this, 16 months of disease control, but if the disease is quiet, it's not continuing to mutate. You are preventing the development of additional resistance mutations, which could lead to shorter PFS with subsequent lines of therapy, something that we are waiting to see from Serena-6. But this idea of helping prevent increases in resistance is another benefit of the earlier introduction of the doublet. So I think it's a very provocative question, but it doesn't necessarily negate the benefits of using Serena-6 approach.
Maroun, when do you think is the optimal timing for serial ESR1 mutation testing in routine care? When do you think you should start testing for it?
That's a good question. I think I would delay it a little bit. I think first of all, you increase the yield of finding an ESR, and then, not giving up, for example, on your hormonal therapy. I would give it like 3 to 6 months to start testing.
Serena said after 6 months, but if you look at it, correct me if I'm wrong, Erica, a lot of these patients weren't at 6 months. They were much further on in their therapy. I think you just wanted to get everyone recruited. So I think, personally, I think you need to look at a lot of factors. I think those patients with maybe very low burden of disease, single metastasis, like what PADA-1 actually told us when Francois actually presented his data last year at ESMO Breast, that there are certain groups of patients who will inherently do very well, and maybe you could delay their testing versus the ones that have disease from top to bottom. But I personally would probably follow Serena-6 and say at least 6 months. Aref, when would you ideally begin ESR1 monitoring following initiation of AI plus CDK4/6? Would it be at 6 months? Would it be at 12 months? And how often would you do it?
I think, as we mentioned earlier, currently we are doing at the progression, but based on the Serena-6, we're starting at 6 months and probably repeating every 3 months to detect, an early emerging ESR1 mutation. Before you finish the meeting, I have very quick questions. Just keep for me last 1 minute.
Okay. Husam, what potential barriers, and very quickly, I need you to tell me this, what potential barriers would you face regarding ESR1 monitoring in your clinic?
The finances, if that is an
Dubai
issue,
is free, so please don't tell me finances. Tell me something else.
which I will say, I always say ESR1 for one person is very straightforward. I'm not worried about they said the psychological concerns about waiting for the result. I think for one person it's fine. I think for the health system, it's a burden. So I know that we could get support for some time, but after a while, I think when they start to get the invoices, I think we may have a different game later on. So
Okay.
I cannot say the finance is not an issue. Now, there are a group of patients who will be, you would think that maybe the disease is developing very quickly. For example, you do the test, but you have to be very meticulous to get the CT scan at the same time and make sure there's no progression. How good we are going to be at that, I don't know. I think the trial, the experience will do it. So I will be, if any signs of progression, I'll have to move to the second line in a different way.
Dalia, what barriers exist currently in implementing serial ESR1 monitoring across institutions, do you think, in the UAE? Is it
I
team
think
capacity, sample handling, or workflow?
all of them, because until now we don't have it in-house. So the ESR will come from outside, and we have to upload the test result into the system, and we have to document it into our notes. So it's not there in our system. We cannot monitor it in a serial ways. So sample handling also is an issue. So for example, the last 2 months, it was difficult to send any sample outside because of the issue of the whatever there. So a lot of factors actually, we don't have it available in-house. That's why I think that we have a challenge in this issue.
And now we have the kit in our lab, Dalia.
Yes.
Yeah,
Yes.
the kit available, but sending it outside and putting it into our system, this is the issue.
And Emad, once you get the results, how are you going to communicate ESR1 monitoring to your strategy to your patients? Because I've heard this whole spiel about patients will get more anxious, this, that, and the other. But Erica, you know, in our society over here, all patients are anxious all the time, 24 hours a day, 7 days a week. I think this will give them a level of comfort that we are actually on the job monitoring things really in real time. So, Emad, what are your thoughts here?
It's easy. I will tell her you're lucky you have now a resistant mutation of better endocrine therapy than you are receiving. I will add it from tomorrow. So it's an endocrine therapy. Just change
But
is
but
inhibited
based,
another endocrine
based
therapy.
based on no radiological progression, because some people now are abusing adding camizestrone, as Serena 6, but it is not Serena 6.
But we haven't actually started. The tablets have just arrived, so I don't think there's been any abuse yet. If there has been, please refer the case to me and I will stop the abuse immediately.
It's just changing the endocrine component. So from aromatase inhibitors to camizestrant, so which is better efficacy. So I think it will be easy to discuss with the patient because
Yeah.
it's endocrine therapy. It's a very well tolerated. Patient will not feel any difference.
Erica,
And
simple
better
question.
tolerated than AI as well, Emad. You're
Absolutely,
absolutely right. You're
absolutely.
absolutely right.
Erica, very simple question for you. You know, hopefully the FDA will catch up with the UAE and approve Serena 6 very quickly. But having said that, in your mind, in your clinic, how often are you going to be testing for ESR1 mutation and for how long?
Yeah, so I think it's a great conversation and thinking about how we operationalize this. So first of all, I would be following the Serena 6 guidance, meaning that I would not start until patients have been on their first line therapy for at least 6 months. In general, per Serena 6, the testing was every 2 to 3 months. I tend to scan my patients every 3 months. So that's 4 times a year. So I'm sending ESR1 4 times a year. I would send this test 2 weeks before the visit where I meet with the patient to talk about the scan, because it takes 2 weeks for me to get the result, and it's too complicated to see the patient to talk about the result of the scan and then 2 weeks later have to call them with an extra value. I will say that having taken care of many patients in the step 1 portion of Serena 6, patient anxiety was not a big factor. And patients who were having the ESR1 testing done, exactly as what was pointed out, they welcomed this information. They thought it was really interesting. They really were glad that we were interrogating the tumor and interrogating their bodies. So I did not have patients suffering from what we sometimes refer to as scanxiety. It was quite the opposite. It was a welcome thing in our practice. So, I think there are a number of logistical issues to work out. I will also add that for patients in Serena 6, once they'd had about 5 or 6 tests done, the majority of patients who were ESR1 emergent were identified. But I will say that some of those patients were many years into their first line therapy. So we can't say that, let's say a patient has been on their treatment for 4 years and their disease is fairly quiescent, that they don't have this. They still potentially could have emergence of an ESR1 mutation. So I wouldn't put a limit on how many years they've been into treatment or specifics of the disease state. I would think about more how many times have you tested and is it worthwhile to keep going after a number of tests?
So this was your study, which was the PRO assessment study. And here again, there was the ERTC oncology specific, and then of course the breast cancer specific. Questionnaires are actually given to patients at various time points, and the time to deterioration in global health status and quality of life was actually worse for AI plus CDK4/6 versus CAMI plus CDK4/6. And interestingly, you presented this last year at ESMO looking at pain, fatigue, and shortness of breath. And across the board, it was better for CAMI plus CDK4/6 versus AI plus CDK4/6. But Erica, I've heard a lot of people comment that, it's probably not reflective of what actually is happening. And especially they couldn't understand how shortness of breath would be an endpoint to look at. Maybe you can explain this a little bit, because I understood it, but a lot of people didn't.
Yeah, so actually, if you go back to the first slide with the global quality of life deterioration, you can see that these curves separate very early on into the experience. And I think on first glance, folks thought, well, maybe this is just toxicity differences between camizestrant and aromatase inhibitor. Maybe it's just a better tolerated regimen. And that's why patients are reporting an improved or a sustained quality of life compared to those on aromatase inhibitor. The reason why that doesn't totally make sense, though, is first of all, when you look at the toxicity tornado plot in this trial, it's really fairly symmetric. There's not a substantial amount of toxicity that's contributed by camizestrant versus aromatase inhibitor. It's fairly balanced. Additionally, remember, the patients had to have been on their first-line therapy for at least 6 months. So they were at a point where they were fairly stable with their treatment. It would be strange for them to enter the study and then immediately have worsening symptoms related to the regimen that they've already been on for at least 6 months. When you look at this data, pain, fatigue, shortness of breath, these are not symptoms of side effects from medication. These are symptoms of subclinical disease progression. So my interpretation of this is that what we are seeing here is that patients who switch to camizestrant with CDK4/6 inhibitor are having prevention of disease progression, and thus it's preventing the side effects which are associated with disease progression. Shortness of breath, that reflects cancer getting worse. That's the thing that is being prevented here. So I think it's a really nice way to have the patient's voice telling us that they feel better because they're not having their cancer get worse, which is, of course, the main goal of what we're trying to do with all of this.
All right. So then we also had physical ability to perform everyday activities, impact of health on work, and even emotions. I found this very interesting. Dalia, what are your thoughts here about the feelings of depression and irritation was actually better with CAMI plus CDK4/6 versus AI plus CDK4/6? And then I'd like Erica to comment on this.
I think it's great to have this impact or better in terms of emotional impact. It's good, but again, how they assess it emotionally by just the questionnaire. Practically, I need Erica's comment about it.
Erica?
Yeah, I mean, I do think it's quite compelling that in terms of physical ability and role functioning, this is, distinctly improved with switching to camizestrant. But the emotional piece, I don't think this is because camizestrant helps improve our mood. I think if you look at the curve, the curves really begin to separate around 9 months. That's when the control arm was progressing. So they were changing therapies, and of course they're going to feel upset about that. So I think what we're seeing is if you have prevention of disease progression, you feel better, emotionally and physically, which makes total sense.
So now let's move on into the realm of co-mutations, which we've talked about a little bit earlier on. You can see from the Emerald study, if you give elacestrant in the presence of a PIK3CA mutation and an ESR1 mutation, it worked, and it worked very well. If you look at Evera, again, it worked very well in the presence of a PIK3CA mutation as well as an ESR1 mutation. And if you looked at Capitello 291, it didn't really matter whether you targeted, all patients were targeted for the AKT alteration, but it didn't really matter if you had an ESR1 mutation versus no ESR1 mutation. And we had this very nice paper that came out earlier this year, which was a network meta-analysis that essentially told us that when they pooled all the data from all the randomized clinical trials, and you looked at those tumors that had an AKT alteration, it actually didn't matter whether you were targeting the ESR1 mutation pathway versus the AKT alteration. So, Maroun, what is your preference in the presence of a co-mutation? What do you target, assuming you can do combo? Because I've asked this question before, and everyone says, oh, because we can only use elacestrant monotherapy because that's the only thing approved. But if you look at the NCCN guidelines, they actually tell you now you can use combo for oral SERDs. So, and you now have Serena-6 that tells you can use combo. So use the combo and tell me, which pathway are you going to actually target?
I mean, as you mentioned, I mean, it really in general doesn't matter. But I think when you start using the combos of oral SERDs and CDK4/6 or everolimus, I think this is gonna have major impact on even Serena-6, meaning a second line. I mean, the combos are gonna change the way we think about things. For now, I think the commutations, when the combo is in, it's not important anymore. Especially
Emad, you have a patient that is second-line therapy, has an ESR1 mutation as well as a PIK3CA mutation. How do you decide what you're going to do, assuming you can do combo therapy for both?
Definitely, I'll go for combo.
I know you're going to give combo. I want to know which pathway you're going to target.
We have Evera trial. If it's approved, probably it will be the best combo.
So
But
okay.
until now, I will give PIK3 kinase inhibitor plus fulvestrant.
So Erica, NCCN guidelines say you can use imlunestrant in combination with a BEMA, and you have Capitello. Which one are you going to use? Does it depend on the VAF? I've heard a lot of that in the community. I think it shouldn't. Do you think it depends on the tumor burden? Do you think it depends on other factors?
Yeah, so I definitely look at the entire clinical picture to understand which pathway to target. I feel humbled by PI3 kinase mutations and how we consistently see really inferior outcomes in the absence of appropriate PIK3CA targeting medications when those tumors are being treated. And so my tendency is to go after that mutation first, particularly in a patient with a greater burden of disease, shorter durations of prior lines of endocrine-based therapy. But in a patient who has lower burden disease, who's had long durations of therapy previously, who has the co-mutation, then I would be inclined to try targeting the ESR1, as has been said, only in the setting of using a combination regimen. So, I don't think there's a one-size-fits-all approach here, but we have to incorporate all this different information that we have. And again, what I think we want is the combination that targets both of these mutations.
So Erica, let me ask you this question. We are going to have patients in Serena-6 that are going to have a PIK3CA mutation and an ESR1 mutation. And say, suppose I get a patient in my clinic, Serena-6, I'm giving her CDK4/6 plus camizestrant. She stays on it for like 12 to 20 months. Upon progression of disease, she has significant disease progression with a lot of liver mets, lung mets, bone mets. Should I do Capitello at that point in time? And if I do Capitello, will fulvestrant really work with capivasertib at that time, having used an oral SERD already? Because these questions are going to come up in the community.
Yeah, I think that's a great one. And we really don't know what the activity of fulvestrant is going to be after a patient has had an oral SERD. We do have a history of, recycling endocrine backbones and using, the same backbone even beyond progression with switching out the targeted partner. So it may be in a situation like that the capivasertib would be the lead agent and the fulvestrant is playing a smaller role. But that would also be a patient, if they're progressing quickly with a heavier burden of disease, that one might begin to think about whether chemotherapy would be the next step or antibody drug conjugate type of setting.
So I wanted to bring to your attention that AMBER-3 actually, when I saw the data, it looked like imlunestrant and abemaciclib actually worked irrespective of the presence of an ESR1 mutation. Plus, we had data, and I haven't put it up here. We had data from San Antonio last year that showed us the data from Elevate that looked at elacestrant and abema and elacestrant and everolimus, and it worked irrespective of the biomarker being present. So, Dalia, do we even need to, test for biomarkers upon progression of disease? Should we be giving combo-directed therapy to everyone? Why are we testing?
This is a valid question. Yeah, if it is working irrespective of the receptor, this is a valid question. And I think it was asked during the San Antonio last year. whether we need the test or not. I think till now we need to test.
So, Erica, I just skipped through the slide, but when I looked at Victoria, and Victoria one had gatalysis plus fulvestrant plus minus palbociclib, the data that was presented last year at ESMO was actually amongst the patients who didn't have a PIK3CA mutation. And it worked very well. Yes, there were a lot of caveats around this study, apart from the fact that, you were giving an IV medication, and there were all sorts of other caveats as well. But again, I'm repeatedly seeing that you don't really need to test for an ESR1. You don't really need to test for a PIK3CA mutation. These combos seem to be working across the board. So should we only be testing like SERENA-6, where we're looking at molecular progression and targeting those pathways, and then if there is radiological progression, just use what you have?
Yeah, it's a provocative question. Do we still exist in the realm of precision medicine? And it's tempting when you see these studies that show broad activity to say maybe we need to walk back from all this testing and just give regimens to larger groups of patients. That feels wrong to me. There's been so many decades of work trying to understand and untangle all of the mechanisms of resistance and understand how to have greater ability to precisely target all of these different steps, and to pull back from that and no longer care what's going on in the cancer. That just doesn't feel very modern. It doesn't feel right to me. I will say, though, that after we've already assessed our PIK3CA status, after we've already decided if ESR1 has emerged or not, beyond that, there's not a whole lot more we're going to learn from continuing to do genomic testing. So it definitely has a role earlier on in treatment, but later on, particularly a more endocrine pretreated patient, there really isn't going to be more we're going to get out of that, and we may need to look at other ways of assessing the cancer or deciding which strategies to use. I'll also just add that I think the Victoria data is a little challenging to interpret, in that, as you pointed out, this is an intravenous therapy in patients who are not typically getting intravenous therapies. And there are fairly high rates of stomatitis seen in the study despite prophylactic use of steroid mouthwash. So it's not totally clear to me how gedatolisib would enter our clinical space given the other options that we have available, even though it is very provocative data, particularly compared to fulvestrant monotherapy.
So in the last couple of minutes, I want to discuss what about when patients receive adjuvant CDK4/6 inhibitor, because that's the space, that's the reality that's going to happen in the next couple of years. And this is a study that actually comes out from your institution, Erica, looking at patients who had recurred on abemaciclib, and 50% of these patients had developed triple negative breast cancer at the time of recurrence. So my question to you, Erica, you've got SERENA-6. How do you implement SERENA-6 once a patient has relapsed on adjuvant CDK4/6 inhibitor?
Yeah, so you bring up a really important question nowadays, now that we have really global penetration of adjuvant CDK4/6 inhibitors with both abemaciclib and ribociclib. Thankfully, these drugs work extraordinarily well, and I think we've all anecdotally seen fewer recurrences than perhaps we saw in years past. But they do happen, and one of our fellows, Chiara Corti, had this recent publication looking at outcomes. And what it shows is that for those who recur on or soon after adjuvant, in this situation it was abemaciclib, these are very resistant cancers. Half of them have lost estrogen receptor, 90% have TP53 alterations, and the median duration on first-line endocrine-based therapy was just 3 months. So I don't think for these patients that our best first step is an endocrine-based step. This may be a situation where perhaps upfront ADC is a better option. Even if we started them on endocrine therapy, if they progress in the first 6 months, they would never even be eligible for SERENA-6. So I don't think this is the SERENA-6 target population. That being said, some of the long-term follow-up from monarchE has begun to look at treatment patterns on those who relapse early versus late. And those who relapse many years after adjuvant CDK4/6 inhibitor, their disease profile may resemble a more typical metastatic recurrence, and perhaps that is a group of patients for whom one could use a SERENA-6 approach and consider if that would be a way to go. But I think that's an area where we really do need to generate more data and understand what to do in those situations.
In the last couple of minutes, I want to ask the question, we saw that the Persevere study has a negative press release telling us that when you use an oral SERD upfront compared to an AI, and both arms of the study used a CDK4/6 inhibitor. Now we haven't seen the data, but it looks like it was probably similar. So, Aref, what are your thoughts there? Why do you think that that has been a similar outcome? When we have Serena-6, it tells us that probably oral SERDs need to be better in these patients.
If I understand the question well, I think, we are, because we are treating early biological, progression rather than radiological progressions, because, by the study, you have median progression at about 16 months, but our 9 months or 10 months, however, in our clinical practice, as you said earlier, patients are staying for a longer and longer duration on CDK4/6 inhibitor. I have still patients on palbociclib that's more than 7 years and 8 years. So probably that's why in the study we're seeing like probably same overall survival. I will take the opportunity to ask my question because you forgot me. I have a patient.
I haven't finished yet. Good. Before you ask your question, let me ask Erica the same question.
Okay.
Erica, I think the reason why Persevere has been a negative study, and again, I haven't seen the data, I'm just completely hypothesizing, is one, they use a CDK4/6 inhibitor in both arms of the study. I think we've forgotten the results of Parsifal that told us when you used fulvestrant versus AI with CDK4/6, both arms did exactly the same. And third, I think in order to see the superiority of an oral SERD above an AI, you need to enrich it for an ESR1 mutation cohort, which was not there in a first-line setting. Very quickly, what are your thoughts? And then we'll go to Aref because he has a burning question that he wants to ask you before we
And
leave.
Husam, it seems, also has comment or something.
Yeah, so those are really exactly the two main questions I have about the trial results. And what is the role of CDK4/6 inhibitors? Does that just overwhelm any benefits you get from the endocrine backbone? And we would expect in the first line setting the rate of ESR1 mutations to be very low, and so it doesn't give you the opportunity to see the benefit. But then how do we explain lidERA in the early stage setting where we also expect a very low rate of ESR1 mutations? I will say that the other first-line study, Serena-4, is a larger trial, and it may have greater power to be able to detect efficacy signals. So I think we need to wait for that data to better understand what the role would be for SERD and CDK4/6 inhibitor in the first-line setting. But I think we're all eagerly awaiting the negative data so we can better understand what happened in that trial and how to move on from that.
Aref, very quickly, what is your question?
Very shortly, patient progress on adjuvant aromatase inhibitor. She's in her 50s. She had liver and leptomeningeal. She was treated with localized leptomeningeal, treated by radiotherapy, put on fulvestrant, abemaciclib. Now 6 years free of disease. By MRI, by PET scan, she said, I cannot tolerate anymore the injection of fulvestrant because now I cannot even sit because of 6 years of monthly injections.
Give her elacestrant.
She has no ESR mutation. Am I allowed to give elacestrant plus abema based on the elevated trowel? Yes or no?
Yes, I say yes. Erica, do you say yes?
I don't have access to that regimen.
No, but if you had access, would you say yes?
I mean, I would probably do imlunestrant just because that's the data, that's the
Oral
phase 3
SERD.
data.
You'd give an oral SERD.
Yeah, but I think an oral SERD and a little whisper of the abemaciclib.
Absolutely. Husam, last comment because we have to log off.
No, I think Dr. Erica said it very clearly. Is about everything was very clear till we got lidERA out positive. So what will be interesting is what's the beast we're going to see at the end of it. So what type of biology we're going to see at the end. So the whole thing is going to have to be reformulated again and reformatted.
I think Husam, if I could just comment on that, I think also lidERA did not use CDK4/6 inhibitor, and that is why you're seeing a difference. I think had they used a CDK4/6 inhibitor, and we will see that probably with some of the other studies, we may not have seen a difference in that first line setting. But again, you've all been awesome. This has been probably one of the most interesting discussions I've had in a long time. Thank you, Erica, for giving us your insights. I wish I had more time. I would probably have given you questions for the next 6 hours, but we are going to see her
Just
in
glad it's
Dubai
over.
end of the year. She's coming to us for the EIOC, hopefully in November. So we look forward to hosting you, Erica. Arif, thank you. Emad, thank you. Dalia, thank you. Maroon, thank you. And Husam, thank you. And I hope to see you all
Thank you,
in the
Shaheenah.
next
Thank you.
edition
Bye-bye.
of the
Good night,
Thanks,
EIOC.
all.
everybody.
Bye-bye.
Thank you. Take
Bye-bye.
care. Bye.
Bye. Thank you.